Then primary biliary cirrhosis, PBC, primary biliary cirrhosis. So mostly this one will be caused by early autoimmune damage to bile ducts with granuloma formation, mainly intrahepatic bile ducts. Remember, bile ducts will have one that would be intrahepatic, that is inside the liver, and you can have extrahepatic, that is outside the liver. So in this case, there is autoimmune damage. So the body produces antibodies against the liver cells, and so the liver cells are destroyed. So the early autoimmune damage to bile ducts with granuloma formation. We talked about granuloma, so go back and revise again. So later interface hepatitis, then you have ductular proliferation and progressive fibrosis. So later on you have the hepatitis, you have the ducts proliferating, just like in chronic, then you have fibrosis. So chronic inflammatory disease of the liver in which destructive, so though biliary cirrhosis, primary biliary cirrhosis is basically chronic inflammatory disease of the liver in which destructive inflammatory changes are centered primarily on the bile duct. So this one, the destruction is mainly on the bile ducts, centered around the bile duct, and that's why we call biliary cirrhosis. So there is vasculation of the epithelial cells. Remember, those ducts, they have an epithelial cell. That is basically the cells that are lining the inside part of those ducts, so epithelial cells. And I remember we talked about the epithelium in Anatomy 1, and also in the histology when we were talking in Anatomy 1. So there is vasculation of the epithelial cells and infiltration of the wall and surrounding tissue by lymphocytes. So if you to look at the microscope, you see a lot of lymphocytes. And of course, it affects usually females more than the males. So 95% of the time it will be women, aged 35 to 70 years. So those maybe we may consider them as middle-aged. And as I said, this male to female ratio will be 1 to 9. So there are more females affected than the males. And usually the T cells attack the bile ducts. So this one will generally lead to impaired bile formation and secretion, leading to cholestasis. Stasis is stationary. So in that case, you have biles that is not moving as well, because these ducts are likely to be destroyed or even blocked. And so you have what you call cholestasis. Yeah, so bile is pulling up and it's not flowing as it should. So you're looking at the primary biliary cirrhosis. That's a diagram. If you were to do, if you were to prepare it and look under the microscope, this would be some of the things that you will see in the liver. Yeah, as I said, mostly it will be intrahepatic, that is within the liver. You can see bile ductular proliferation. Those ducts increase in number, they proliferate. There will be lymphocytes, so there will be a lot of lymphocytes forming, lymphoid aggregate, you can see there. And then there will be formation of fibrosis, that is basically scar formation. And then there will be nodules. You form what you call micronodules, because you see around it there is fibrosis, and then you have parts that are normal. So you end up what you call micronodules. Then cirrhosis. So cirrhosis mostly will be most of the hepatitis, if it is not well controlled, it's likely to lead, that will be almost the end point of any liver problem, especially talking of inflammation, will be cirrhosis. So in cirrhosis, there is diffuse process. The diffuse process, end stage of chronic liver damage. So generally, mostly it will be the end stage of chronic liver damage. So there is formation of regenerative nodules divided by fibrous bands. Even as we have seen in the primary biliary, there are those fibrous bands, and then they will be regenerative. So there will be some cells that are regenerative. Remember, the liver is one of those cells that have the ability actually to regenerate if it is stimulated accordingly. So there will be some regeneration of cells, and then there is fibrosis around it. So you end up with what you call micro modules or nodules. So it's characterized by wholesale disruption of the liver architecture. So the architecture of the liver is affected in total, with the formation of nodules of regenerating liver cells. So the cells will be beginning to regenerate, that is, increase in number, new cells are being formed. And these are separated by fibrous bands, because remember, this is a healing process. So healing, mostly you'll form fibrosis, you end up with scarring. So these are the main effects. You will have disordered hepatocyte function, so the function of the liver cell will be affected. There will be disturbance of blood flow through the liver from the portal vein to the hepatic vein. Because there is fibrosis, so those veins are likely actually to be narrowed or even blocked completely because of this fibrosis. So there will be a disturbance of blood flow through the liver from the portal vein to the hepatic vein. Remember, from the hepatic vein, now it goes to the inferior vena cava and goes back to the right side of the heart. So there is vascular obstruction, and that is what leads to portal hypertension. And that is what also leads to varices. For example, you can have varices, basically it's dilated vessels, because basically the blood that was supposed to go to the portal vein is supposed to try and find alternative routes. And so one of the alternative routes will be vessels around the lower side of the esophagus. So you end up with esophageal varices. It will also be those vessels around the anal region. You end up with hemorrhoids and others, and even vessels around the umbilicus. So you end up with what we call caput medusae. That is, the vessels around the umbilicus become dilated because those are the channels through which the blood that was supposed to go to the liver is supposed to find a diversion for it to be able to get back to the heart. And of course, there are many causes, which including chronic alcohol abuse, that is basically alcoholism, where you're taking excessive alcohol. So that can lead to cirrhosis. Chronic hepatitis, you have those viruses that can cause, among other things. So that in itself, if not well controlled, leads to cirrhosis. Biliary cirrhosis, we've already talked about, that affects mainly the bile ducts. Cryptogenic cirrhosis is a small percentage. That is basically, most of the time, we may not be able to get the cause. So in that case, there is no underlying cryptogenic cirrhosis. There are no underlying disease which can be found. So you examine, you do everything, you can't find it. That's the one we call cryptogenic cirrhosis, but it's a small percentage. And then, of course, if you are to confirm the diagnosis of liver cirrhosis, it is confirmed by percutaneous liver biopsy. Percutaneous liver biopsy is basically you pass a needle through the abdominal wall and then all the way to the liver and get a small tissue from the liver and then prepare it and look at it under the microscope. That's what basically we mean by percutaneous liver biopsy. There is a biopsy where you can actually open the abdomen and go directly and cut the liver. As I told you last time, biopsy, you can have incisional biopsy, you can have excisional, you can even have just you're looking at cells, and then you can have core biopsy. This percutaneous will probably be like core biopsy. You're using a needle to just get part of it and looking. And then, of course, there is a diagram showing alcoholic cirrhosis, and you can see some of you have to look at it grossly. You will see micronodular cirrhosis, nodule less than 3. So they will be very small. Yeah. So, but the liver, if you are to feel it, will be just generalized nodularity. It will feel like there's nodules all over. Yeah. So, unfortunately, we don't have physical class, but I think in a physical class, generally, it will probably have been better in trying to demonstrate some of this thing, but we have to work with what we have. So, we have alcoholic cirrhosis there. That is on the right side, we have the micrograph. That is, you're looking under the microscope, you've stayed and everything. So that's what you're likely. You can see those nodular-like structures, and you can see what is separating. That will be the fibrosis. And then you can see from the diagram, there is fibrocepta, that is this. And then there between them, you have micronodules. And then you have the ductular proliferation. Those are the ducts. Basically, the bile ducts tend to proliferate, increase in number. So that's what you're likely to see microscopically. Then effects of cirrhosis in the liver, which I've already mentioned when I talked about the clinical features of the hepatobiliary disease and their pathophysiology. I can see there's a diagram there. And you can see one of the things we have talked about, coma. We are talking about encephalopathy, can be change in consciousness, altered consciousness, which can lead even to coma. Yeah. Then you can have jaundice, which you've already mentioned. You can have spider navy. Basically, these are bruising, and they appear to be some darkening or change in color under the skin. That's what we call spider navy. So they will look like a spider, and it is to radiate from a point. Yeah. And then we have pectoral alopecia. Alopecia basically is there's decreased, the skin become pale, as in there's loss of color. So the skin is likely to appear white around that area. Yeah. And when you talk about alopecia, also you're talking about, for example, loss of hair. Yeah. So loss of hair. Actually, alopecia is more or less loss of hair. So there'll be loss of hair around the chest region generally. And then gynecomastia, we've already talked about. Of course, you are likely to have liver damage. You can see that liver has probably cirrhosis. It's a cirrhotic liver. Ascites, which we've already talked about, an accumulation of free peritoneal fluid. There is altered hair distribution. So the hair changes. There may be even loss of hair around the pubic region and other areas. And then the testis is likely to atrophy, that is become smaller, atrophic, smaller. And then hemorrhagic tendency, we talked about bleeding. And I think I said the reason why you're likely to have easy bruising and bleeding and so on. You're likely to have edema, which you already mentioned. So basically, this hepatic insufficiency. Basically, the liver is not performing the function that it was supposed to perform optimally. And so you end up with all this. And then one of the results, of course, you can have portal hypertension. And when you have portal hypertension, these were likely to have bone marrow change, esophageal varices. Those are dilated vessels around the lower part of the esophagus, because of basically the blood of the portal vein is trying to find another route to be able to get back to the heart. And so you end up with esophageal varices, you end up with splenomegaly, you end up with distension of abdominal veins. For example, the caput around the umbilical region, we call it caput medusae. And then you end up with also ascites as a result of portal hypertension. I think the next is just the same diagram, another diagram just showing the same hepatic encephalopathy that includes coma. Jaundice, we've already talked about. Fetal hepatitis, basically fetal hepatitis, you are referring to bad breath. So somebody who has a liver problem is likely to start having a bad breath as a result of the liver damage. So we call it fetal hepatitis. Coagulopathy, problem with bleeding and coagulation. And then, of course, within the lungs, you're likely to have what we call vascular shunts. That is basically the blood. Some places will not be well vascularized within the liver, within the lungs. Then gynecomastia, we've talked about. Spider navy, we've talked about. Ascites. And also, you are likely to have what we call hepatorenal syndrome. That is basically the failure of the liver can likely to cause failure of the kidney as well. So we call it hepatorenal syndrome. You should be able to look at it and be able to get more detail. When you talk about syndrome, you're thinking of many signs and symptoms that could result from certain condition. Then, of course, testicular atrophy, which you already mentioned. There also we have a diagram of which already we've mentioned of portal hypertension. What consequences? What is likely to happen if the blood is not flowing well through the portal vein to the liver? What is likely to happen? Yeah, if you have liver cirrhosis, for example, you can see that liver looks cirrhotic. So you are likely to have esophageal varices, which we already talked. You are likely to have hemorrhoids. You are likely to have caput medusae, that is the blood vessel. So if you look at the skin of the abdomen of such a patient who have caput medusae, you will see dilated veins radiating from the umbilicus. So that's what we call caput medusae. When we talk of caput, it refers to the head. So that place looks like the head, and then there are veins radiating away from that umbilical region. So I think when we finally be able to meet in a physical class, this is one of the things that probably I'll just run through just to let you get to understand. I think there'll be some things I'll have to look at specifically when we are able to have a physical class. Basically, those are some, and then you can see the portal vein, abdominal wall. You can see the umbilical vein, and so on. You see, you should be able to look at it and see why we have those caput medusae and so on. And then, so be able to try to look at those things like veins of Sapera, try to look at them and you'll be able to understand. And then, of course, sinusoids are likely to become dilated and so on. So those are some of the consequences of portal hypertension. Then I think we move on to tumors. Yeah, because liver, just like any other organ, will be affected by tumors, both malignant and benign. So hemangioma would be one of them. Hemangioma will be one of the tumors that will affect the liver. So it's a benign proliferation of blood vessels. When you hear of hemangioma, mostly it has to do with blood vessels. So there is benign proliferation of blood vessels in the liver. So blood vessels increase in number within the liver and to form a mass. And that's what we call hemangioma. So if you look at the liver, it's one of the commonest benign tumor of the liver. So if you look at the liver and you see a tumor and it turns out to be benign, most of the time it will turn out to be a hemangioma. And most of the time it's a common incident of finding on imaging, autopsy, or laparotomy, and most of the time tend to be asymptomatic. That means there is no symptom. Somebody doesn't have any pain or anything. So it's usually found incidentally. So incidental is something that you are doing something else for another reason. Maybe you are doing abdominal CT scan for other reasons. Then you discover in the liver you can see a mass. And then autopsy is post-mortem. Maybe after death you do post-mortem, then you find that somebody has had a hemangioma. So mostly it's incidental. Or during laparotomy, for me as a surgeon, as I'm doing surgery, maybe for another reason, or most of the time when I open the abdomen, I will be able to see, and I should be able to look at all the organs, including the liver. So I may examine the liver. Maybe the problem was issue with the intestine, but when I examine the liver, I realize there is a mass, which turned out to be, so it's likely to be a hemangioma, so incidental. So benign tumors of vascular tissues, which most commonly occur in the skin, that is skin and liver. So this one tend to occur, sorry, that's the skin, so there's a typo there. So usually tend to occur in the skin and liver, these hemangiomas. So they tend to occur in the skin and the liver. So many are present at birth or soon after and may be considered as hematomas or developmental disorders. So we'll check about hematomas, then we'll be able to know the difference. And then, so these hemangiomas can be divided. There are some we call capillary and others we call cavernous. So capillary type is composed of small capillary sized spaces. So the spaces are like capillary. They are small. They are the size of capillary. That's what the one we'll call capillary hemangioma. And then cavernous hemangioma composed of light dilated vascular spaces. Yeah, so that's what we call cavernous type. And usually, if you to look under the microscope, you'll see that they are lined by normal endothelial cells. Remember, endothelial cells, when you talk of endothelium, basically you are referring to the epithelium of blood vessels. Of course, the liver is one of the main organs where metastasis or cancers from other areas of the body, the colon and other areas, can spread to. So that's what basically we call secondary hepatic tumors. That is basically metastatic cancers from other areas of the body, the stomach, the colon, or other areas. So most of these hepatic metastasis, most of the tumor that goes to the liver, most of the time is from the GI tract, that is gastrointestinal tract. Most of the time in draining through the portal drainage, because there is a portal vein that drains the gastrointestinal system, the stomach, the large intestine, the small intestine, and they all drain through the portal vein. And so it's likely to if there is a cancer that gets into the blood from the stomach, it's likely to go there. So another place that cancer of the breast can also spread to the lungs. Also, cancer of the lung also can spread to the liver. That's basically the cancer of the breast can go to the liver, of the lung, of the colon, of esophagus, of the pancreas. Also, malignant melanoma can spread. We look at malignant melanoma also, especially when we come to the skin. And usually there is tendency to be multiple. That means you will find a lot of them within the liver, not just one mass. It will be multiple masses within the liver. And mostly this one will result from hematogenous spread. Remember, we talked about in pathology 1 about the spread of malignancies. It could be hematogenous, it could be through the lymphatics, it could be even local spread, and so on. And this one induces a stromal reaction in the form of fibrous connective tissue containing blood vessels. So there is what we call angiogenesis. Angiogenesis, angio refers to blood vessel, and genesis. So there is formation of new blood vessels. So usually these tumors within the liver will tend to cause fibrous connective tissue to form. There is that reaction and formation of new blood vessels. And this one usually will be more common than primary hepatic tumors. So if you compare these metastatic tumors with the primary tumors that start within the liver itself, usually more common. Usually they tend to be multiple spherical nodular masses which are of variable sizes. And of course, these metastases will tend to make the liver enlarged and heavy. So if you are to do examination, you may find that the liver is enlarged. There's what we call hepatomegaly. And if you are to measure, the liver will appear heavier. And the tumor deposit, if you are to look at them grossly, they will appear white, well demarcated, soft. It could be soft, it could be hemorrhagic. That means it could be bleed. It can also bleed into those tumors. And so that they become hemorrhagic. And then when you look at the surface of the liver, it tends to show characteristic amplification due to central necrosis of nodular masses. When you talk of amplification, you know, umbilicus there's a depression. So there will be some depression in it because of necrosis of those nodular masses. And of course, these are some of the investigations that we can do to try and look at the liver, not necessarily because of the cancers, the metastasis, but for any other cause. You usually do liver function test, which is a blood test. A CT scan of the abdomen will be able to show you the liver, and so if there are any metastases or any other lesions within the liver, you are likely to see with a CT scan of the abdomen. Also, the MRI of the abdomen will be able to show you the liver. And if there are any lesion within it, you probably will be able to see. Also, ultrasound. From most of the time, the first investigation we will do for if we suspect something in the liver would be the abdominal ultrasound, so that you're able to see the liver. And then, of course, another test that you can do is the percutaneous liver biopsy that we talked about. You're going through the abdominal wall into the liver and getting some tissue for histological investigation. There you see just a diagram and a gross specimen of metastatic deposit in the liver. You can see those nodular metastases. You can see amplification, basically a depression. Yeah, amplification is like the umbilicus. Most umbilicus will be depressed. If you look at your belly button, usually depressed, so amplification. And then you can see it can bleed into those tumors. And so you have hemorrhage there into it. And because they can necrose, there's been necrosis around there. That is the gross specimen. Of course, it's not very clear, but that is how probably if you are to take the liver that has metastasis, there will be a lot of nodular whitish areas all over because of metastasis. Then we have hepatocellular carcinoma. Yeah, we call it also hepatoma. That is just known as hepatoma. So primary malignant tumor arising from the hepatocytes may secrete bile. So this one occurs from the liver cells themselves. Hepatocellular carcinoma, unlike metastasis that we have just talked about. And this one may secrete bile still. Yeah. Then there is something called serum alpha fetoproteins, which is useful as a serum marker. So if you were to do a blood test and look at for the alpha fetoproteins, in cases where there is hepatocellular carcinoma, the alpha fetoproteins will be elevated. Alpha fetoprotein will be elevated, and that in itself can help you suspect probably somebody has hepatocellular carcinoma. And mostly for hepatocellular carcinoma, unlike the metastasis, it will tend to be a single nodule. So you see a single mass within the liver. So, and hepatocellular carcinoma is closely related to the prevalence of hepatitis B virus infection. So, in a place where there is a high infection of hepatitis B virus, there'll probably be an increased incidence of hepatocellular carcinoma. So, in some parts of Africa, it accounts for up to 40% of all cancers. So, in scenario in places where hepatitis B is prevalent, then you are likely to have even up to 40% of cancers being hepatocellular carcinomas in developing or developing countries, basically third world countries. But if you look at those developed countries like Europe, USA, it accounts for only about 2%. So most of the hepatocellular carcinoma in those developed countries will not be resulting, few of them, only around 2% will be from hepatitis B infection. And remember, cirrhosis of any cause also predisposes to its development. So if you have cirrhosis from any cause, it increases the risk of developing hepatocellular carcinoma. Yeah, so cirrhosis of any cause predisposes to the development of hepatocellular carcinoma. And this carcinoma is associated with rapid clinical progression and average survival from diagnosis only around 6 months. So usually it tends to progress very fast. Basically, from the time of diagnosis to death, we are talking about only 6 months. So it has a very poor prognosis. So it tends to progress very fast. From the time you diagnose, for example, to the time of death would probably be just around 6 months. The survival will be, so the prognosis usually is very poor. May form a single massive nodule, multiple, but sometimes it cannot form, but most of the time it will be a single node, but it can form multiple small nodules. Or of course, it can also have diffuse infiltration. That is basically infiltrating all over the liver, not in a specific way. So there's no proper demarcation, just spreading all over the liver. So of course, like any other tumor, any other cancer, it can either be well differentiated, poorly differentiated. So sometimes poorly differentiated tumors form irregular duct-like structures. So it's likely to form structures that appear like ducts, those bile ducts. Then very well differentiated hepatocellular carcinoma may produce well-formed ducts and even secrete bile. So well differentiated, when you talk of well differentiated, the cells, the cancer cells look like the normal. As in you can see and know that these are hepatocytes. And so they can even produce, they can even secrete bile. So I've already said it's also known as hepatoma. So hepatocellular carcinoma is also known as hepatoma. It's a most common primary malignant tumor of the liver. Most common primary, remember, is the one that occurs from the tissue itself. So it's not coming from another tissue. It is arising from the hepatocyte. So it's the most common primary malignant tumor of the liver. Male to female ratio, so it tends to be more in male than female. You see the ratio is 4:1, so more males than females. And usually tends to occur, the peak incident, that is the time where it's more common or is mostly diagnosed around the 5th and 6th decades of life. I suppose those are from the 50s to the 60s years of age, that area, 5th to 6th decades of life. That is where most of the time these hepatocellular are diagnosed. Hepatocellular carcinomas are diagnosed around that time. So tumor supervenes on cirrhosis in 70 to 80% of cases. So in 70 to 80% of cases, it tends to come following cirrhosis. So in a liver that has cirrhosis. So most of them tend to occur in situation where the liver is cirrhotic or has cirrhosis. So if you took the what we call macroscopic patterns, if we talk of macroscopic as opposed to microscopic, macroscopic is what you can see even with the naked eye, that is grossly. So you can have patterns like expanding type, where you just have one single massive nodule, and then multifocal type, where we have multiple small nodules, and then you can have infiltrating type, diffuse infiltrating type, so it's just diffuse all over the liver. So we have risk factors for development of hepatocellular carcinoma. It includes hepatitis B and hepatitis C infection. It also includes cirrhosis from whatever cause. Also alcohol, especially if you have alcohol, if you excessive alcohol use and you also have hepatitis B and C infection, it increases the risk of developing hepatocellular carcinoma. That's what I mean there by alcohol plus hepatitis B and C. So it makes it worse if you are using alcohol with hepatitis B and C infection. You can have, of course, mycotoxin. Myco has to do with fungus. Mushrooms, all those will be fungus. If you, for example, there's what they call aflatoxin. For example, if you don't store well your crops and so on, they're likely to develop aflatoxins. And if you take those food, there will be toxin that is likely to lead to cirrhosis and can increase risk of developing hepatocellular carcinoma. Of course, there are some chemicals that are carcinogenic, that is, can cause cancer, including even tobacco smoking increases risk of. So these are risk factors. It doesn't mean necessarily this will lead to cancer, but it increases the risk of development of hepatocellular carcinoma when you have those risk factors. Those are the macroscopic patterns, expanding, multifocal. You can see those yellowish, that is the tumor, that yellow appearing. And then you can see the infiltrating type. And then, of course, looking at it microscopically, under the microscope, you can see the diagram on the left showing the main features that you're likely to see: the tumor cells, cirrhosis, trabecular sinusoidal pattern, multinucleate cells, nodules. Those are the things that you're likely to see under the microscope.